All right, good afternoon, everybody, and thank you for joining us for lunch. I want to thank our sponsor, Abbott Vascular, for hosting this lunch symposium here at New York Endovascular Summit. I hope you guys are having a great day. It is a lovely day in New York. And I'm proud on behalf of my co-investigators to be kicking off this symposium to talk to all of you about the Esprit BTK drug-eluting resorbable scaffold system for infrapopliteal chronic limb-threatening ischemia. I am an associate professor at Columbia, not far from here, and notwithstanding the traffic, it's exactly 22 minutes from my office to here. And I'm delighted to give you a device overview. I think it's obviously well known to this audience that for the below-the-knee circulation, there's a number of unmet clinical needs because these vessels are small in diameter, often challenging anatomy, with long lesions with calcification, in which case a ideal treatment would subsume many of the properties that we get from different technologies. One, it would have a drug to inhibit neo-intimal hyperplasia after intervention. Two, it'll have a scaffold to actually resist acute recoil, which is a big problem. And three, it will leave nothing behind, ultimately to preserve future options for other therapies. The Esprit BTK system offers many of these characteristics. And just for those that are not aware, the device was initially introduced as a monorail delivery system and has recently been also reconfigured for an over-the-wire delivery system for those that are more familiar with that technology. The resorbable scaffold backbone is made out of polylactic acid, or PLLA. It is covered with a PLGA copolymer that releases everolimus with an anti-proliferative drug dose density similar to the Zions family of coronary drug-eluting stents. There are 4 platinum markers, 2 on either end, that will help you identify this otherwise radio-invisible technology. And there are balloon marker bands that are situated exactly at the ends of the scaffold. These are the 2 delivery systems that are currently available. Again, there's now a new over-the-wire platform that is 143 centimeters in length. And then there's a traditional monorail system that many of you are familiar with that's 145 centimeters in length. It's 5 French sheath compatible. And the size matrix is important to note is from 2.5 to 3.75 millimeters in diameter, in lengths from 18 to 38 millimeters. It's 014 guide wire compatible, and again, the guide wire lengths that are recommended are obviously the short wire for monorail and 300 centimeter wire for the over-the-wire catheter situation. Nominal deployment pressure is 9 atmospheres with a rated burst on the balloon of 16. It's important to note that the strut thicknesses are much thinner than first-generation bioresorbable scaffolds, and the 2.5 and 3.0 device is 99 microns, and the 3.5 and 3.75 is 120 microns, with a radial strength equal or greater to that of the Zion scaffold. And again, I want to point that out because this is a question we get all the time. These devices are as radially strong or greater than the current generation best-in-market Zion's platform. Importantly, though, the overstretch capability is only 0.5 millimeters above nominal. So if you have a 3.75 diameter scaffold, you can post-dilate it to 4.25 before you will disrupt its radial strength and its integrity. I think as everybody's aware, the device is a drug-eluting device for roughly 120 days, and then it starts to lose through hydrolysis its structural integrity after 12 months and is completely resorbed by 36 months duration. The overall findings that are just as in this histopathology slide deck from earlier generation devices, that the device is embedded in the vascular wall, and over time on cross-sectional analysis, you will see basically a collagenous matrix replacing the struts of the scaffold itself. Again, if you look at earlier studies, we've had excellent primary patency all the way out to 5 years. And this is from Ramon Varco, our colleague and co-principal investigator in Australia, with a primary patency out to 5 years of 72% in this study that enrolled back all the way to 2018. And then with that as a motivating factor, the Life BTK trial studied 261 patients randomized 2-to-1 OUS and US in over 50 global sites to, again, PTA versus Esprit BTK implantation. The primary data were presented at 12 months in 2023 with a simultaneous New England Journal of Medicine publication, which led to FDA approval of this device. And subsequently, last Viva, my partner, Dr. D. Robertis, presented the 2-year data, which as of yesterday or last couple of days was published in Circulation, demonstrating not only that we had excellent primary patency and freedom from binary restenosis, clinically driven TLR, and ipsilateral amputation compared to PTA. As you can see here in the 1-year primary endpoint, a 30% absolute risk reduction. But now this is almost identical out to 24 months. And again, these data were just published in Circulation in this last week after going through rigorous peer review. Importantly, as we would expect, the biological efficacy of these devices is in the inhibition of intimal hyperplasia and reduction of restenosis. And as you would expect, the TLRs in the scaffold group are roughly half of that which are seen in the angioplasty group. And this trend seems to be growing, that the difference between scaffold and PTA arms seem to be separating further over time with respect to clinically driven TLR. So with that, I'm going to hand over to Dr. Liz Genovese from University of Pennsylvania. She's going to give us the more interesting part, the clinical application of this now FDA-approved technology. Thanks very much.
Well, thank you, Sahil, and thank you, Abbott, for this opportunity. For those of you who don't know me, I am a board-certified vascular surgeon, so in addition to these disclosures, I think if my affinity for femoral endarterectomy didn't indicate to you kind of some of my conservative nature, this kind of will. And the 2 cases that I wanted to show today are going to demonstrate how I have changed my practice in the utilization of the bioabsorbable scaffolding. I know there's a lot of different practices when it has come to up to this point with tibial scaffolding, and different backgrounds tend to be a little bit more have a little bit more of affinity for bailout coronary stenting or using coronary stenting off-label to help keep their patency for tibials. I have always been fairly conservative with that. And so when I compared the number of coronary stents I had put in tibials over the past year, it equated to the number of bioabsorbable scaffolds I put in within the first month once I got this on the shelf. And so I just want to use these 2 cases to illustrate how I've changed my thinking about bioabsorbable scaffolding and how I'm approaching tibial interventions. So this is my first case. This is a really sweet 59-year-old female, very poorly controlled diabetes, underlying CKD, who presented with a wet gangrene of her foot. And she kind of went on for a hot case. The podiatrist called me and said, I got very little bleeding from this foot during the case. So did some non-invasive testing, flat live weighted forms at the metatarsal to signify significant disease, and took her for an angiogram. She had some pretty prevalent multi-level disease, went ahead and treated her external iliac artery in order to get better inflow into the leg. Her SFA had a little bit of disease. I touched that up with a DCB as well. But then really kind of the meat of this is her tibial arteries. So she has a perineal going to her foot. Her collaterals off of her perineal really are not feeding a very robust plexus of her foot, but you can see her AT is present, reconstitutes very collaterals, is very underfilled after her occlusion, and then turns out does feed an intact pedal loop. So initially the way I would normally approach this is I would angioplasty. I'd start with a small balloon, then maybe hit her with a bigger balloon to hit the reference vessel diameter, and then that would be my day. So I did an initial angioplasty with a 2.5 millimeter balloon. And you can see I have this residual stenosis there. I hit it again with a 3 balloon to better hit the reference vessel diameter size. Looked pretty good, a little bit of residual stenosis. Now, typically in this part, I may take a non-compliant balloon and hit that and then hit it again with a prolonged balloon angioplasty. But ultimately, because I know that I have this on the shelf, instead of doing that and probably having more recoil that's going to happen once I get the patient off the table and then have this go down in a short order fashion. Remember, she has a very large tissue defect that I'm trying to heal. I elected, this is a type of case where I'm going ahead and I'm using balloon bioabsorbable scaffolding. So I utilized a single 3 millimeter by 28 millimeter spree stent. And you can see here on the picture, the most prevalent markers that you're seeing, that's the markers of the balloon. It's a little bit harder to see that the markers of the stent. Typically what I do when I'm deploying these, I kind of mag up. I have the luxury of a computer magnification, so I can mag up. And when you do mag up, you can see those stents quite easily. And so ultimately, we were able to take a recoiled tibial vessel that I would have probably given an inadequate treatment to, and I have nice balloon scaffolding and bioabsorbable scaffolding, and ultimately, she's about a month out and still has a palpable pulse, and she's healing her TMA. So the second case is a real departure in how I've treated tibial vessels. So this is a 48-year-old female, end-stage renal disease, diabetes, all the markers of below-the-knee disease. She recently just had a left above-knee amputation, and this is what her foot looks like on the right. So we're really trying to do everything we can for limb salvage for her. So she has a persistent sciatica artery, which is just important so you understand the images I'm about to show you, but ultimately has evidence of arterial insufficiency and probably some microvascular disease as well. So it came up and over, secondary to the fact that we want to engage in the internal iliac in order to get access to her popliteal artery. And she had a little bit of proximal disease, again, treated with a DCB, but here is what our tibials look like. Pretty typical for what we would expect in a diabetic patient. And you can see she has significant TP trunk perineal disease, but her AT is what really is filling her foot, and she has a completely intact pedal loop. So what we did was we crossed this lesion and this is our cross lesion, and did just an initial angioplasty, because when you do the bioabsorbable scaffolding, you want to make sure that you're getting full luminal gain before you put the scaffolding in. You know, while Sahil said you do have nice radial strength with this, you want to make sure you can get that vessel open before you place your scaffold. So we had nice opening with a 3 millimeter balloon. The more recalcitrant portion, we did actually hit with a jade balloon to try to get a little bit more expansion with that, and then ultimately placed three Esprit stents right abutted next to each other to cover the entire area that presented with occlusion to avoid a geographic miss. So this is a situation where I got my ideal angiographic result from my angioplasty alone. And typically 6 months ago, before I had this on the shelf, I never would have thought about scaffolding this for a second. But this is where we're thinking about it in a different manner. These patients need these arteries to remain patent without significant stenosis for a prolonged period of time. We're not just healing a wound, we're also keeping them from getting recurrent wounds, and anything that we can do to maintain that vessel patency for as long as we can, I want to try to do, right? And so this is a beautiful angiographic result, and I think that it is really important that as this continues to develop and as longer bioabsorbable scaffoldings come out, we can see how this plays out, particularly in the proximal 2/3 of the tibial vessels. And you can see now that we did that, she has a nice intact pedal loop, and she's going to heal her amputation site. And I just want to take a quick moment. Out of curiosity, who in the audience has used the Esprit PTK stent? Okay, so it's a little bit different to deploy than a typical stent. You do go up a little bit slower as you inflate it. You want to do about 2 atmospheres every 5 to 10 seconds, and then you leave it inflated for 30 seconds to kind of let that polymer fully expand and oppose the wall. The other thing that's a little bit different than what we're used to with stent deployment is you essentially are having about a minimal overlap between the stents, about a 1 millimeter overlap between the stents. You're not overlapping them significantly significantly. I know that we have the thought process from above the knee, are we covering things by a centimeter? So this is just a 1 millimeter overlap. And so what you will see when you do that is on screen right, you can see the little markers of the previously deployed stent. And on screen left, you can sometimes see the little markers of the stent you're about to deploy, but you can very clearly see the markers of your balloon that is holding your stent. So if you line the balloon marker right up to your previously deployed stent, those stents are going to line up perfectly with about 1 millimeter overlap. And so that's kind of the algorithm that you need when you do need to lay multiple scaffolds down. So just a little tip from my standpoint. So two kind of cases that kind of demonstrate how my practice has changed for below the knee. And, I'm excited as some of these longer stents come out because I'm sure I will be utilizing them. But
Great. Thank you, Liz.
Yeah, of course. Any questions?
Yeah, actually, so I think we have some work to do since there's not a lot of people who are still using the device yet. But I think your point was very well taken. I think these two cases illustrate sort of the spectrum of disease. It's rare that we get a focal lesion like that
Right.
first case, but the recalcitrant recoil, all of us encounter that. And in years past, many of us might have used a coronary DES off-label for this application. Here
Right.
you have an on-label device with excellent clinical data. But for the second case, you made the point about geographic miss.
Yes.
Do you want to sort of just elaborate on that? Because I think that's a concept that's been co-opted from the coronary literature. But I think in other disciplines, it's not as well understood. You want to just go over that for a second?
Yeah, and I think that people are figuring out exactly their algorithm when it comes to these longer lesions and utilizing the bioabsorbable scaffolding. But essentially, a geographic miss, the way I understand it and the way I see it in my practices, is that you have a lesion that you've treated, you've angioplastied, but yet you're only providing your drug elution in certain areas of that lesion, whereas the entire area that you have angioplastied is going to have an inflammatory process. You are going to get an intimal hyperplastic process. And so in those areas that you are not laying your bioabsorbable scaffolding, you are essentially undertreating it, and you're missing that area where you could potentially now have that area restenosed because you haven't given it the appropriate treatment.
Yeah, that's exactly right. So, I mean, this concept was really sort of originally identified in coronary intervention, where patients would get pre-dilatation with a balloon angioplasty, and then the stents would not cover the area that was injured. And you would frequently, if you were injuring on both sides of where the scaffold was placed, would get what we called candy wrapper in-stent restenosis, where the edges where the balloon had protruded outside of the stent zone would wind up with intimal hyperplasia. Here, and in the clinical trial, importantly, it was mandated that if there was balloon dilatation, the entire segment would be scaffolded. So if you want results like the clinical trial, you'll have to, we think, perform the intervention like the clinical trial. Certainly, that in the first case where you might have ballooned a longer segment than where you treated, that's a reasonable approach, and you could certainly apply that sort of bailout scaffold approach. Mm-hmm. But I think to recapitulate the results of the trial, we would probably recommend that you treat the entire segment. Prakash, you have some of the world's greatest experience with this device. Any tips or tricks that you want to convey to the audience?
Yeah, definitely. But I want to ask Liz a couple of questions, if you don't mind, Sahil.
Yep.
One is, so Liz, when you talk about vessel prep, right, and sizing, how are you sizing? Are you IVUSing a lot of these lesions in order to truly get the size of the vessel? And are you using, and how are you characterizing the plaque? Is it by fluoroscopy, or is it by just IVUS?
Oh, I think that's an excellent question. So for whenever I am using any kind of scaffolding below the knee, I'm absolutely IVUSing, because I think that the importance of getting the right scaffold size is critical to its performance. You don't want to drastically oversize it because you don't want to cause that mismatch in the shear forces at the edge of the stents, but at the same time, you don't want to undersize it and miss getting that luminal gain. If I'm being honest, I think there's a lot of people who probably take a balloon up and see how that balloon matches the vessel below it or above it and kind of estimate based on that. I don't think that is an unreasonable way to do it, but we have technology that can give us so much more discrete information that can really change the outcomes of what we are doing. And if you are going to take the step to place a bioabsorbable scaffold and you are going to use the money to do that, and you want the best outcomes you can get, I think IVUS is going to be the way to go. I mean, even if you're not familiar with IVUS and you just start using it for reference vessel diameter, then start to do that. And as you keep seeing more and more images, you'll start to get the difference between, okay, is my plaque eccentric? Is it concentric? And am I seeing a lot of calcium, or is it more fibrotic? The more you see the images, the more you'll feel comfortable doing that. And so if I do see a lot of calcium, I will make sure that I am going to do some sort of IVL or some sort of prep, whether it's IVL. Other people may use orbital atherectomy, but to modify that calcium so that you can soften it, so you can really let that stent oppose and expand to get the full luminal gain.
So Sahil, just a question to you and Liz as well. I mean, we all using these, and guys, please, any questions, please ask. But my question is, how are we dealing with the restenosis? How are we dealing with, when these do go down? Because in the past, as you know, in the real world, we were doing spot stenting and failing quite a bit. Mm-hmm. And I'm just curious on how you guys are dealing with that.
Yeah, I mean, the short answer is that the TLR rates are surprisingly low. In my hands, we've done, I don't know, probably 100 cases. We've had one TLR where there was diffuse proliferative ISR. Oftentimes, the only thing open are the scaffolded segments. Mm-hmm. And so if you come back through, if it's greater than, let's say, 4 weeks, you can easily recross these, but the recommendation is to do it with a looped guide wire so you don't get under a strut, just like you would cross any implanted stent. And then certainly you'd want to image to understand the mechanism of failure. Was it underexpansion? Was it diffuse proliferative in-stent restenosis? Was it something else, thrombotic or otherwise? Interestingly, in the trial, there were no stent thromboses. Roughly, it was mandated that patients were on DAP for a year. If you look at the actual data, in both the POBA and the scaffold groups, about 3/4 were on DAP at 1 year for no particular reason in the POBA group. And we did not see any scaffold thromboses in the first year, and we've seen none in the up to 2-year follow-up. There are proliferative ISR cases, but as you saw, the TLR rates are roughly 2 to 1. And continuing to sort of diverge. So I think, certainly if you see it, you got to understand the mechanism and address that mechanism in particular.
I'm going to hog up again and ask one more question. So in terms of, I know this is an Abbott talk, but how far down do you go with the scaffolds? I mean, obviously, those of us who take care of CLTI, we're forced to do things below the ankle and so on and so forth. And there have been some case reports, or I should say talk, about putting these scaffolds, if needed, below. I mean, have you had an experience with that? Or would you not talk about it? We'll talk
the
short
offline. Answer is that the IFU says 10 centimeters from the mortise of the ankle. The truth is that Ramon and others, OUS, who've had greater experience with these devices in a prior iteration, have said that, if you're within 5 centimeters, you're probably fine. But the IFU is 10 centimeters.
No, and I think you also just have to think of the compressive forces that the distal tibials undergo, right? So definitely not across the ankle. You're under very tight fascial linings, and then as you start to really get towards the ankle, and particularly like the perineal artery or the anterior tibial artery, you tend to get a lot of compression between the tibia and the fibula, and so I think 5 centimeters is probably the absolute limit I would go. I tend to stay away from the distal third at this point. I'm sure as we get more technology and we get a little bit more facile with it, and we see, as we do see this, there's some degree of stent failure, and we get to understand what that methodology is, we'll push the limits a little bit more. But for right now, just knowing the actual compressive forces that I see when I'm doing cut downs, when I'm doing I'm staying above the distal third.
Yeah. Professor.
Yeah, I have a question. If I well understood, after 36 months, there is no more evidence of stent starts within the vessel.
Yeah, so that's all preclinical data. So the 3-year data we're going to present at TCT next month. But theoretically it's gone by then.
It is the time frame the same for the smaller and the larger size, because
yes,
it's the same. Also, if the thickness is higher.
Yeah, based on the preclinical animal models, yes.
Okay.
Yeah, in vivo, if you do intravascular imaging with OCT especially, you might see some sort of shadow artifact of where it was, but on histopathology, the device itself, the PLLA matrix, is fully replaced by a collagenous matrix. So it's an endogenous, substance.
So, quick question over here for Dr. Genovese. One of the great advantages of this technology is that it's bioresorbable. Yeah. So, in your experience, what are your thoughts on the fact that we're not really burning bypass targets down the line, or has been your experience with that?
Well, what I would say is that any area that you're laying scaffolding in is probably not going to be a good target for me to bypass to. Ideally, the thing about preserving targets for a bypass, the key to is as you're doing your crossing and your intervention, as long as you're not injuring the healthy vessel, that's the critical portion. So where there's the downfall, where targets become more distal, is when, let's say, you're getting very aggressive with the popliteal occlusion and you take your dissection plane down a little bit more distal, and all of a sudden I had a baloney pop target and now I have to go to a tibial. Careful with our pedal access, being very gentle with it, using the appropriate techniques to minimize the injury to your pedal access. I access the foot probably 20% of the time with my angiogram, so I'm not against that, but it's maintaining the health of your normal vessel. Anywhere where you're going to be laying scaffold, I'm not going to be able to use that as a target anyways.
So Sahil, in the, I'm sorry. Oh, go ahead, Moeen.
Oh, yeah, I have one question about sizing these scaffolds. It's not uncommon to have tibials that are 4.5, or we commonly have proximal tibials that are longer, or even TP trunks. So I've shied away from putting these scaffolds and used just coronary stents. I think we should have bigger size. Any comments on that? I think the biggest size we have is 3.75, which can probably go up to 4, but not more than that. I've had a case where I actually put this one in, and then patient came back with an occluded stent. I had to put in a drug-eluting stent inside that because the size mismatch. So even if we do the IVAs, these stent sizes, I think that's a major limitation of the current availability of the...
Yeah, I guess I would argue that this is the first generation of tibial technology, and you're right, there isn't a complete size matrix. I think if you see that the vessel is larger than 4 1/4, realistically, you probably would have to use an alternate approach. Coronary DES now, we're able to make them close to 6 comfortably, and so you have lots of options in the non-bioresorbable devices. But I don't think that this device is appropriate for vessels of that size. Not yet, anyway.
I know this is an Abbott talk, but I want to ask about those 2 patients that you talked about. Any role of the retrievable spur stents from reflow, or any experience with that?
Sure. I think that there are a lot of technologies out there right now that are focused towards vessel prep and changing the compliance. So you have the reflow spur retrievable stent, which is really about changing your compliance of the vessel and decreasing your recoil and getting more luminal gain without dissection. The limitation of that stent, or let's say the Serenator, which is also another kind of vessel prep, changing your compliance, IVL, you're not delivering any kind of drug elution with that. So right now, as it stands, this can be used in adjunction to your vessel prep. Those wouldn't take the place of your bioabsorbable stenting.
Just a question, Sahil and Liz. As you know, in the trial, and I think we have a slide that talks about the return of the physicity of so I know you're not certain of whether you could bypass to that, but is that a demonstration of endothelial health, and could that mean that you could bypass once these bioabsorbable devices are absorbed?
Yeah, I can't comment about the bypassability. I'll let Liz talk about that. But there are some exploratory data, and we're actually in the midst of a detailed analysis looking at every patient in the trial to look at the phasicity of the duplex. So what we're talking about is that we've observed, and Prakash, you've helped us with this, that in patients at 2 and 3 years when duplex was mandated, that the vessels, which usually when they're stented look like a monophasic lead pipe, have a return of triphasic waveforms, which is unusual, and suggests that there's a restoration of vascular compliance that would be not seen in a typical metallic scaffold. We're looking at that very carefully, and the core lab is painstakingly going back through all 261 patients at 3 individual time points and reporting the individual phasicity of each target lesion and target scaffold. So you can imagine the amount of work being invested in that. But so we think that that's sort of demonstration of the value proposition of the bioresorbable technology. Whether that's bypassable or not, I'll hand that hot potato off to you.
Yeah, I don't know. I think that's time will tell. I mean, I'm sure we'll see as we start cutting down on these vessels in 2-3 years, and we see what they look like on duplex, and the elasticity and compliance of it. We'll see, but
Too early.
Yeah, we have one more quick talk, and I'm going to invite Barbara to come up. There are important questions about reimbursement, and there's some really important updates that we have to share. So without further ado.
Yeah, so my name is Barbara Kind. I am the Director of Health Economics and Reimbursement for Abbott Vascular, and pleased to be here today to help support this really amazing new technology with the reimbursement side of it, which we all know is something that, at least in our role within the companies, we view our role as enabling you to do what you do best. And so hopefully we have some, going the wrong way again. So the good news is that we do have reimbursement for Esprit BTK. We had a very unique situation with Esprit where, despite the fact that there was actually a CPT code that's been in place for, since about 2010, 2011, there has never been an FDA-approved device to actually be able to be used in that particular CPT code. So we use the existing tibial perineal CPT code, and also have then hospital inpatient, hospital outpatient, ambulatory surgery, and office-based lab reimbursement, and professional as well. Just a quick note on the inpatient and the outpatient side. On the inpatient side, depending on what type of vessel prep you use, that will determine the series of MSDRGs that the procedure is likely to be assigned to. I say likely because obviously with MSDRGs and inpatients, it's a combination of both the procedures as well as the complications and comorbidities of the patient that ultimately determine where the algorithm lands. But if it's angioplasty alone, it will fall in the 252 to 254 range. If there's atherectomy that gets used, it gets moved into the 270 to 272. And then on the IVL side, it gets moved into 278 and 279. So again, it's one of the pieces that go into the algorithm to determine eventually where this is likely to land from a reimbursement perspective on the inpatient side. And I'll talk a little bit more about inpatient in just a second. But I also wanted to hit the outpatient side. Here we have, we compared in Life BTK the standard of practice, which was balloon angioplasty. So if you do balloon angioplasty in the tibial perineal, it is a 5193 or level 3 endovascular APC or ambulatory patient classification or ambulatory classification. Paid on a national average at around $11,000. Here, obviously, in New York City, and it's a bit more because of the higher wage index and higher payments overall. If you do add Esprit to the picture, you get moved to the 5194 APC, which is paid on a national average around $18,000. Again, here in New York, it's more like 22. So there is room on the hospital outpatient side in the difference between balloon angioplasty alone or balloon angioplasty with an Esprit scaffold or two. The good news is we just received CMS NTAP, or New Technology Add-on Payment approval, that begins October 1st, so in a couple of weeks. NTAP is the program that CMS has to enable some of the costs of the new technologies to be partially offset as a part of the inpatient process. And so our NTAP payment cap, which is the maximum that you could add to the MSDRG, is $69.2250. Make sure you get that 50 cents there. But that's up to 65% of the actual costs of the device. The important thing to keep in mind when you're doing this on an inpatient basis is that you need to use the very specific Esprit BTK ICD-10 PCS codes. So make sure your coders are aware of that. Make sure they use those codes, because that is what's going to trigger the background analysis of whether a patient qualifies for NTAP. In order to qualify for NTAP, the cost of the procedure has to be higher than what the hospital would get reimbursed from an MSDRG perspective. And then the payment level that gets added to the MSDRG is the lesser of the difference, up to 65% of the cost of the technology. So I know it's a little complicated. We have lots of resources available to help sort through that with your business office folks. But the good news is it's there. We are additionally working on, well, before I jump into that, the basis for the cap, we were able to go back to CMS and say, you know, Esprit BTK or Life BTK study was obviously a bit shorter lesions than you typically find within the tibial perineal, because you know, it was a controlled study. We wanted to reduce the number of variables, but in real life, when you see these patients, there's a very wide range of lengths of lesions that we're treating, and so we did a fairly deep analysis and came up with an average. Weighted average length of lesion of 135.1 millimeters, and based the NTAP calculation cap on that average patient in the real world evidence that we were able to simulate. So the NTAP cap is based on a technology cost of $10,650, and then 65% of that is obviously the $6,922. We are working on reimbursement for the outpatient side of the hospital as well. There's a couple of comparable types of approaches for new technology, incremental reimbursement, and we are actively pursuing those. We do realize that can be challenging on the outpatient side for folks as well. ASC, obviously the stepchild of the hospital outpatient, in terms of the costs being set at a little bit less than the overall hospital outpatient costs or the payment rates. And then on the physician side, we have both the facility, which is what you get paid as a physician for when you practice and perform these procedures in the hospital, inpatient, outpatient, or ASC setting, and then the non-facility, which is essentially the OBLs. This is what the OBL payment levels are, and that includes not just the professional services component, but the entire overhead and cost structure of performing those procedures in the office-based labs. Coverage is something we don't talk a lot about, but it's a really important thing, particularly for breakthrough new technologies. Medicare has one local coverage determination policy for non-coronary vascular stents, and typically what the MACs will do is allow that to be interpreted across the country. Medicare Advantage is where we have, as a society, really started to see a lot of prior authorization requirements, and the necessity of appropriate documentation for the medical necessity of the procedure in order for the procedures to get covered and paid. Medicare Advantage is supposed to be covering and paying for everything that traditional Medicare covers and pays for. So we, again, are working to support you with resources to be able to make sure that those patients that need this therapy get access to it appropriately in all of the different payer areas. What we have seen is that the commercial payers are getting very, very specific, particularly for the lower extremity revascularization procedures, about the level of specificity with which their benefit policies are written. And so make sure you know, again, working with your business office and the coding and reimbursement folks, what that specific patient's benefit level is, the policy that they're working under, and supporting them to get prior authorization, which will likely be required on the commercial and the Medicare side. But the good news for all of this is that we are not seeing non-coverage decisions for this important new therapy. We are seeing it get covered and paid for appropriately for CLTI patients. And we expect that, given the results of the Life BTK study and the sustained results of the Life BTK study, that we should be able to continue to provide that. So here's just a list of resources. Again, lots of stuff on our website. There's a QR code that you can scan to get access to that. Feel free to call our hotline. We have a specialized field reimbursement team. Anything that we can do to help you and your business office as you start to use these procedures, we're happy to be able to do so.
Thank you, Barbara.